Today our topic of discussion is on rhabdomyosarcoma, orbital metastasis, and craniosynostosis. By the end of this presentation, the audience should be able to describe the features, subtypes, and treatment modalities of orbital rhabdomyosarcoma, describe the features of metastatic orbital tumors, and describe the features of several craniosynostosis. First, we'll discuss about orbital rhabdomyosarcoma. As we know, a rhabdomyosarcoma is a tumor of skeletal muscles. It is commonest primary orbital malignancy of childhood, and 90% patients present before the age of 16, while average age of onset is 5 to 7. Orbital rhabdomyosarcomas account for 25 to 35% of head and neck rhabdomyosarcomas and 10 to 20% of overall rhabdomyosarcomas. Uh, Basically, they are derived from undifferentiated mesenchymal cells or embryonic cells having potential to differentiate into striated muscles in the future. Some association has been found with the retinoblastoma 1 gene. There are several subtypes of this tumor. The first one is embryonal, which shows a good prognosis and a good degree of differentiation. We know that whenever a tumor is well differentiated, prognosis is usually better. Second subtype is alveolar, which is less differentiated and hence having a poorer prognosis. Chromosomal translocations are a hallmark of this tumor in cytogenetic analysis. The third type is pleomorphic, which has the best prognosis overall, but it is the rarest and it is the most differentiated. Found mostly in young adults. In histology, there are strap-like or rounded cells, and on trichrome stain, you may find cross striations. The fourth type is boteroid, which has a grape-like appearance, and usually it is not found as a primary orbital rhabdomyosarcoma. It usually manifests due to extension from conjunctiva or some other areas. Basic features of orbital rhabdomyosarcomas. Classically, it presents as a tumor in child showing sudden onset and rapidly progressing unilateral proptosis. If the tumor is found in early teens instead of the younger age, then the course is less dramatic. There is somewhat slower onset of proptosis. Mostly found supranasally or superiorly, but may arise in conjunctiva or uveal tissue. Swelling and redness of overlying skin is found, but the skin is not warm or there is no pain. So it mimics orbital cellulitis as well, and it is an important differential of it. Diplopia is a common feature. The first picture shows histology of rhabdomyosarcoma. The stain is trichome stain, and you can see cross striations in the central large cell, which is known as rhabdomyoblast.
Use the pointer. How to use the pointer on the laptop? Right click. Right click. You learn to use the pointer. The presentation में देखो कैसे
This is a rhabdomyoblast, and you can see striations in it. The stain is trichrome stain. This picture shows a tumor which is located superiorly. You can see the skin is red, and it looks like orbital cellulitis as well, and it also has a acute presentation like it. This tumor is located inferiorly, and in the axial CT, you can see a retrobulbar mass extending beyond the bony confines into the cranial cavity. You can see the bone is being invaded over here. Again, this picture shows a superiorly located tumor. Coming to investigations, the MRI shows a poorly defined mass. CT also shows a poorly defined homogeneous mass with bony destruction as shown previously. The mass is mostly extraconal but can be sometimes involving intraconal compartment, and sometimes both these compartments may be involved simultaneously. For confirmation, obviously you will need biopsy, and for systemic metastasis you have to perform investigations. The major sites are the lung and bones. This is a CT scan axial view showing proptosis of the eye, and this is the mass. A homogeneous mass is found, and it is poorly defined. There is no capsule as well. Coming to treatment, before 1965 the standard treatment was exentration of the orbit, and it had a poor survival rate. However, after 1965 the radiation and chemotherapy became the primary modes of treatment based on the guidelines set by intergroup rhabdomyosarcoma study group. The mainstay treatment is considered to be chemotherapy. Basically, two main regimens are used: the VAC regimen, having vincristine, actinomycin D, and cyclophosphamide, and the IVA regimen, using ifosfamide, vincristine, and actinomycin D. If the tumor recurs, then you have to go for exenteration. Like basically like any other tumor, if it is confined to the orbit, then the prognosis is better and the survival rates are 90% with radiation and chemo. The next orbital tumors are metastatic tumors from elsewhere. In adults, they are a cause of proptosis but usually less common, and the mets to the choroid are more common than mets to the orbit from the body. Commonest sites are the commonest sites from where the metastasis come. Number one पे breast है, then bronchus, then prostate, then skin, GIT, and in the end kidney. The most commonest manifestations are dystopia and proptosis. Ptosis, diplopia, browny indurated skin. Browny means firm and strong. Firm orbit resistant to manual retropulsion of globe. Enophthalmos, chronic inflammation are some manifestations. Enophthalmos occurs with serous tumors. Serous tumors are basically having a fibrotic element and somewhat leathery consistency. These tumors also occur in the GIT. तो फाइब्रोसिस की वजह से बजाय प्रोप्टोसिस होने के इनऑप्थेल्मिक पिक्चर आती है. If cranial nerves are involved, particularly from 2 to 6 with mild proptosis, then you have to suspect lesions in the orbital apex. Extraocular muscles are often involved in such metastasis because they have rich blood supply, so mets reach there very quickly, and hence you will find extraocular motility problems as well. This patient had a metastatic renal carcinoma showing proptosis both in the axial CT and in the picture. Here is a retrobulbar mass which is poorly defined and not showing any capsule, pushing the globe forward. For investigations, you will go for CT or MRI which show non-encapsulated masses. Lytic destruction of the marrow space of sphenoid in the lateral orbital wall is highly suggestive of METs, because sphenoid में भी जो है वो low flow blood का high volume पाया जाता है. तो high volume of blood means that METs can reach there quickly. Serum carcinoembryonic antigen may be elevated in some cases. For confirmation, you'll go for FNAC, or if it fails, then open biopsy. We have to search for, if the patient is not known to have a cancer, then we suspect that the tumor is a primary orbital tumor, so we have to dig in further. Radiotherapy or systemic chemotherapy, surgical excision of the focus, or exentration, the last resort. These are the mainstay treatment options. Our goal is, चूंकि ये patients जो हैं, चूंकि ये METs usually late stage में present करते हैं, so obviously इनका prognosis already poor होता है. So हमारी जो मेन गोल होता है वो मोस्टली पैलिएटिव ही होता है, हमने बस पेन को रिलीव करना होता है और विजन हमने प्रिजर्व करने की कोशिश करनी होती है। नेक्स्ट टॉपिक इज metastatic tumors in childhood. The first one is a neuroblastoma, which is very common, arises from neural crest derived tissue of sympathetic nervous system, most commonly arises in the abdomen, presents in the early childhood and has a poor prognosis. If we suspect it, if there is abrupt proptosis, superior orbital mass and lid ecchymosis, and these features may be bilateral as well. The upper picture shows CT abdomen. This is the liver, these are two kidneys, this is stomach with air, and this is probably the tumor near the kidneys. And this picture shows the involvement of the superior orbit causing ptosis. You can see the other eye is also involved somewhat, and there is ecchymosis. The second childhood tumor is myeloid sarcoma. We know there are two blood lineages, lymphoid lineage and myeloid lineage. So ये myeloid lineage में कहीं पे rise करता है. Has malignant cells of myeloid origin, it was also known as scleroma previously because it has a green color. It is a manifestation of established myeloid leukemia, but it may precede the systemic disease. And if it precedes the systemic disease, यानी अगर orbital features पहले आ गए हैं, तो diagnosis मुश्किल हो जाता है overall कि patient को myeloid leukemia है कि नहीं. There is rapid onset of proptosis, which may be bilateral, with or without lid ecchymosis and lid edema. The third childhood tumor is Langerhans cell histiocytosis. It is a clonal proliferation of histiocytes. Histiocytes are macrophages in the skin. The disease may have three forms. Either it may be localized to the orbit with bony destruction, known as eosinophilic granuloma, or it may manifest as multifocal bone involvement. Thirdly, a systemic full-blown disease may be found. Soft tissues are less commonly involved, however skin and viscera may be involved. Mostly there is bony involvement. Hence osteolytic lesions may be found either unilateral or bilateral, and soft tissue involvement may occur in the orbit, particularly supratemporally. Hence this tumor is quite involving bones. Solitary lesions respond well to treatment. Systemic disease has worse prognosis. The treatment options basically are intralesional steroid, local curettage, or radiotherapy. This is a picture showing Langerhans histiocytosis. As mentioned earlier, the superior supratemporal orbit may be involved over here. Tumors may invade the orbit from adjacent ocular areas, जैसे कि ocular और periocular areas, like number 1 पे paranasal sinuses है. These are usually diagnosed quite late, so obviously the prognosis is poor, but they are rare in occurrence. Maxillary carcinoma is the most common tumor to involve the orbit. It shows facial pain, swelling, epistaxis, and nasal discharge. Since maxillary sinus is involved, so the dystopia will be upward dystopia, and epiphora and diplopia may be found. If ethmoidal carcinoma is present, then it will cause lateral dystopia. The nasopharyngeal carcinoma may spread into the orbit through the inferior orbital fissure. However, proptosis is a late finding. You can see this is a picture of maxillary carcinoma. There is facial swelling, there is upward dystopia, and somewhat deviated nasal septum as well, and conjunctival ecchymosis. Tumors may involve the orbit from adjacent bony structures. For example, intracranial meningioma may cause proptosis due to spread from the sphenoid ridge. If it arises from the tuberculum celli or the olfactory groove, then it may involve the orbit via the superior orbital fissure or the optic canal. Fibrous dysplasia. Fibrous dysplasia is basically a condition in which the bone is replaced by fibrous tissue. तो fibrous tissue का effect जो है वो एक mass की तरह होता है. Fibrous dysplasia is found in childhood or early adulthood usually. There is facial asymmetry, proptosis, dystopia, and vision loss. Two forms may be found: polyostotic disease or monostotic disease. Polyostotic disease is associated with endocrine disorders and skin pigmentation. It is known as McCune-Albright syndrome. But the orbital disease is mostly due to monostotic form. This is a picture of fibrodysplasia of the orbit. The coronal CT scan shows involvement of the floor and the medial orbital wall. Fibrosis causes mass effect and there is upward dystopia, as you can see in the picture here. Lastly, the invasion into the orbit may occur from the eyelids, like basal or squamous cell carcinoma may involve the orbit. ठीक है, conjunctival melanoma may involve the orbit, or some intraocular tumors like uveal melanoma or retinoblastoma may involve the orbit as well. This shows a conjunctival melanoma involving the orbit, and this shows a retinoblastoma involving the orbit. Again, this is an adnexal tumor involving the orbit. The next topic is craniosynostosis. Craniosynostosis means that the skull fissures, they may close before their usual time, leading to orbital and craniofacial abnormalities. The first syndrome is the Cruzen syndrome. फाइब्रोब्लास्ट ग्रोथ फैक्टर रिसेप्टर 2 जो जीन है उसके वेरिएंट्स, एलेलिक वेरिएंट्स जो होते हैं, वो वेरिएशन की वजह से ये सिंड्रोम प्रोड्यूस होता है, मोस्टली ऑटोसोमल डोमिनेंट. इट इज कैरेक्टराइज्ड बाय अ शॉर्ट एंट्रोपोस्टीरियर स्कल डायमीटर. देयर इज मिड फेशियल हाइपोप्लेजिया, प्रोमिनेंट लोअर जॉ, प्रोप्टोसिस ड्यू टू शैलो ऑर्बिट्स एंड हाइपरटिलोरिज्म. कैन एनीवन टेल व्हाट इज हाइपरटिलोरिज्म? Yes, hypertelorism. Hypertelorism means greater distance between the two medial canthi, and telecanthus means longer medial canthal tendon. Since there is proptosis, so it may lead to exposure keratopathy. Secondly, there may be optic atrophy. Due to these patients have facial abnormality as well, so which leads to sleep apnea, जिसकी वजह से cerebral hypoperfusion होती है और फिर chronic papillary edema हो जाता है. Squint may be found, particularly V pattern exotropia, and amblyopia and ametropia may be present. This is a picture of Cruzen syndrome. You can see there is proptosis, the orbits are shallow, ठीक है. There is mid facial hypoplasia जिसकी वजह से जॉ जो है वो प्रोमिनेंट है, बाकी जो है वो कैंथा के दरमियान डिस्टेंस भी ज़्यादा है. Again, this shows Cruzen syndrome. There is severe proptosis, the orbits are shallow, there is mid facial hypoplasia, and the jaw is prominent, and hypertelorism is there as well. Again, this is a picture of Cruzen syndrome showing proptosis. You can see this is an exotropia. The patient is looking upwards, so V pattern lag rahi hai. The second syndrome is Apert syndrome. Again, fibroblast growth factor receptor 2 mutation may be found. It may be sporadic or it may be autosomal dominant. Oxycephaly is found, which is known as a conical skull. Like the previous syndrome, it has mid-facial hypoplasia. There may be beak nose and low set ears. Syndactyly may be found. Developmental delay may be found in 30% of the patients. Shallow orbits, proptosis, and hypertelorism may be there, but they are less pronounced than the previous syndrome. Complications are similar. This is Apert syndrome patient. Syndactyly is there. ठीक है, mid facial hypoplasia इसमें है और बाकी कॉनिकल स्कल यहाँ पे नहीं अभी नज़र आ रही, दिस इज अ कॉनिकल स्कल, ठीक है। मिड फेशियल हाइपोप्लेजिया भी है और सिंडेक्टली भी मिल रही है। The third syndrome is the Pfeiffer syndrome, autosomal dominant. Again, there is midfacial hypoplasia, downward slanting palpebral fissures. Ocular features are similar to Apert syndrome. This is the picture. Downward slanting palpebral fissure है. It may be comprising of a broad big toe. ठीक है. बाकी midfacial hypoplasia इसमें भी है. बिग टो की एबनॉर्मेलिटी इसमें मिल जाती है। So basically there are three take home messages. In cases of orbital tumors there is ज़रूरी नहीं है कि प्रोप्टोसिस यूनिलैटरल हो, बायलैटरल भी हो सकता है। सेकेंडली रैब्डोमायोसार्कोमा में एम्ब्रियोनल वेरिएंट का अच्छा प्रोग्नोसिस है, एल्वियोलर का पुअर प्रोग्नोसिस है, और ट्यूमर्स कन्फाइंड टू द ऑर्बिट हैव बेटर प्रोग्नोसिस। सेकेंडली अगर एक्यूट प्रेजेंटेशन आ रही है किसी प्रोप्टोसिस की तो ज़रूरी नहीं है कोई इन्फेक्शन ही हो, वो ट्यूमर भी हो सकता है। MCQ. A 4-month-old child was referred with features of mid-facial hypoplasia, shallow orbits, proptosis, corneal exposure, finger and toe abnormality, partial syndactyly and normal intelligence. कौन सा सिंड्रोम है? ये फीफर सिंड्रोम है। जो बिग टो की एबनॉर्मेलिटी है वो फीफर में मिलती है, ठीक है। सिंडैक्टली मिल सकती है लेकिन ये फीफर की पिक्चर है, बिग टो एबनॉर्मेलिटी फीफर में मिलती है। इंटेलिजेंस इसकी नॉर्मल है। एपर्ट सिंड्रोम में इंटेलिजेंस नॉर्मल होती है लेकिन फिंगर एंड क्रूजन में इंटेलिजेंस नॉर्मल होती है लेकिन फिंगर एंड टो एबनॉर्मेलिटी यूजुअली नहीं मिलती। एपर्ट में देयर मे बी एबनॉर्मेलिटी इन इंटेलिजेंस, डाउन सिंड्रोम इज नॉट हेयर। मेनके सिंड्रोम जो है इसमें हेयरिंग डिसेबिलिटी मिल सकती है और कोरोनल साइनोस्टोसिस मिलता है और कुछ बाकी फीचर्स मिलते हैं, तो इसका आंसर फीफर है। Which of the following statements about rhabdomyosarcoma is correct? Commonest extracranial solid childhood tumor, embryonal and alveolar subtypes have genetic alterations that may play a role in pathogenesis. Exenteration widely being used. Orbital tumors are more likely to have alveolar subtype. Orbital tumors are present commonly with ophthalmoplegia. इसका आंसर बी है। कॉमनेस्ट एक्स्ट्राक्रेनियल ट्यूमर ये नहीं है चाइल्डहुड में, ये थर्ड नंबर पे आता है। कॉमनेस्ट एक्स्ट्राक्रेनियल सॉलिड ट्यूमर जो है चाइल्डहुड में वो हमारे पास न्यूरोब्लास्टोमा है और एक और ट्यूमर था उसका नाम मुझे भूल गया, ये थर्ड नंबर पे आता है। एक्सेंट्रेशन अब यूज़ नहीं होती, कीमो ज़्यादा यूज़ होती है। ऑर्बिटल ट्यूमर्स में मोस्टली एम्ब्रियोनल सबटाइप मिलती है। एल्वियोलर जो है ये चाइल्डहुड में अगर एक्सट्रीमिटीज़ का है ट्यूमर, रैब्डोमायोसार्कोमा, लिम्स में अगर ट्यूमर मिल रहा है वो मोस्टली एल्वियोलर सब टाइप का होता है। बाकी ऑप्थेल्मोप्लीजिया इज नॉट अ कॉमन प्रेजेंटेशन। थैंक यू।
So, good presentation. I must appreciate a few points. Number one, he elaborated the terms which he thought were difficult, like brani and cirrus. You see, we don't have to just read from the book. We should understand each and every word of our presentation. And when you think the audience are not able to sort of pick or understand a word, you have to explain it. We don't want to vomit the things which we just copy from the book. Each word which we speak, we should understand what is its meaning. So he explained all the terms. That is a good point. Secondly, there was an article reference of 2023. वो कहाँ से लिया था आपने? गुड। सो पता चलता है कि किसी ने बुक्स के अलावा भी कोई मटेरियल ढूंढने की कोशिश की। ये नहीं कि 2 सफ़े किताब के यहाँ पे प्रेजेंट कर दिया और चलो जी काम खत्म हो गया। सो यू हैव टू सी द लेटेस्ट लिटरेचर कि अब क्या कह रहे हैं। बुक में जो चीज़ें होती हैं दे आर 5 to 10 years बैक, तो नॉलेज जो है ना वो पुरानी हो गई होती है। तो जो लेटेस्ट नॉलेज हमें आर्टिकल से मिलती है, जर्नल से मिलती है, नेट इंटरनेट से मिलेगी। So these were the good points. A few points which I want you